Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today I will be discussing the latest research into the cause of cognitive impairment in patients with systemic lupus erythematosus from Professor Zahi Touma's team at Toronto Western Hospital Lupus Clinic and Professor Murray Urowitz from the Lupus Academy Steering Committee. Zahi and Murray, welcome and thank you so much for joining us. The paper we are going to discuss was published in RMD Open in the end of 2025, and it is entitled Intra-Individual Cognitive Function Course Over Time in Patients with Systemic Lupus Erythematosus. Murray, can you please comment a little bit on how you have seen cognitive impairment in systemic lupus erythematosus along the last decades of your experience?
Well, Raquel, it's good that we're focusing on this area because it's still an area that needs a lot of development. So we've been very interested in patients' symptoms. I can't think straight, I'm not losing my memory, et cetera, brain fog. And we actually, back in 1997, did a study showing that patients with inactive lupus, right? So no detection of active lupus anywhere, had significant cognitive impairment, maybe in about half the patients, and twice as much as you could see in normal age-matched controls. So there was no doubt a cognitive impairment was there. Patients were correct and they were different from controls, and it wasn't necessarily related to active lupus. And when we actually tried to look later on the predictive factors, how can we believe them? What predicts this cognitive impairment? We really couldn't find anything. We found older age or diffuse vasculitis, which is understandable, but nothing specific. Okay, so it's there. It's not clear as what it's related to. So what do we do for it? So when the patient when we see the patient now, if they complain of cognitive impairment, then we go through the usual active disease measures. Is this part of active lupus? And if it is, then we treat the active lupus and hope the cognitive impairment will improve. If it's not associated with very significant active disease, we look for other factors. And here's where the problem is. I've often recently compared this to the finding of proteinuria in renal disease. If you have proteinuria, there's something wrong, but what is it? And we've only recently learned that you don't know what it is until you do a biopsy. Because in the biopsy, you can show either active nephritis or damage or interstitial involvement or podocyte disease. So you can find a lot of different things that are associated with the proteinuria. We can't do a biopsy of the brain. All we can do is order some brain testing, which is usually imaging. The imaging is there, not definitive yet, but getting better. So when we see cognitive impairment and your questions, what do we do? If it's active lupus elsewhere, we treat it. If it's inactive lupus elsewhere, we try to look for some other associated features. And I'll just quickly say, lupus is not one disease, it's many diseases. So you could have lupus due to the immunologic inflammatory mechanisms, which can damage the brain, and you can see that that'll give you cognitive. And then you got what David Pazetsky originally described as secondary lupus. What is secondary lupus? You get brain fog, cognitive impairment, fibromyalgia, and sometimes depression and anxiety. And many of these patients don't have any positive findings. So how do we treat them? So we go on trying to treat them, usually with lifestyle changes, with appropriate non-medical consultations, et cetera, because there's nothing to show that there's active disease. And then we have what I'd like to call type 3 disease, and that's damage. And if you see someone with cognitive impairment and you see some abnormal findings, especially on imaging such as vascular imaging, and you see diffuse vascular disease, you say, oh, this is just dementia associated with deep vascular disease, like older people get very often. And that could be the cause. So I've answered your question by saying, well, there are many, many causes. And when we see the patient, we try to decipher which area do they fit in and then take it from there. So it's complicated.
Yes, thank you so much. Thank you so much. Zahi, I'm going to ask you something that is quite difficult, but how would you define cognitive impairment, just to start with? And how would you define cognitive impairment in lupus? And what are the tools that are recommended for using to use in assess cognitive impairment in lupus? And do they differ from the tools that are used in other diseases?
So I'm going to try to answer all the question. If I forget anything, please remind me.
Don't worry.
And just to build on, Dr. Urowitz really set the stage here very clearly, and I want to continue the story that he started building here with what he told us about what's happened already with the research and so on around the brain. But lupus, even when it comes to the brain, it's not a simple disease, we know, right? And there are different clinical phenotype as well for cognition and cognitive impairment. But before deep diving into this concept, it's very important to refine the terminology and make sure that we're referring to the same thing when we talk. There is a difference between cognitive impairment or cognitive dysfunction and what patient tells us in the clinic, brain fog, or if we want to say cognitive symptoms, probably it's more an acceptable terminology over brain fog. We're talking here about the principal concept of medicine, objective and subjective finding. So cognitive dysfunction or cognitive impairment, it's what objectively the healthcare team, the physician or the psychometrist, psychologist together, they measure something and there is a definition and they say at the end, I have enough evidence to say that the person has evidence of cognitive impairment or cognitive dysfunction, okay? And to do this, you have to use, as you've mentioned, instrument and hopefully standardized instrument and standardized definitions, which we don't have yet. And you can see here, I'm trying to build the complexity and the heterogeneity that we have around this topic. Then the second important, equally important arm is what the patient tells us in the clinic. And we know always objective and subjective complement each other. And cognitive symptoms or brain fog is what the patient report in the clinic. Until now, we have no specific tools, patient-reported outcome for cognitive symptoms in patient with lupus. In the research, people have utilized different instruments to reflect on cognitive symptoms. And in our research, particularly, we've been using lately the PDQ-20, which is the Perceived Deficit 20, a tool that was reported. It's a patient-reported outcome tool that was developed initially for multiple sclerosis, and we've been using it. But there is an ongoing effort by different groups to develop a patient-reported outcome on cognitive symptoms dedicated for lupus. Okay. Now, if you want me to give you a little bit of background, initially when I started the research, I'm a measurement person as well, and I like to make sure that things are very well standardized when we talk about a specific concept. So this is why we did a systematic review almost 10 years ago, or a little bit more. And we wanted to see what is the prevalence of cognitive impairment, objective, okay? And particularly in that systematic review, we analyzed data when a specific study reported a use of a specific instrument. So if it's just based on when the physician or the healthcare team talk to the patient and they make a judgment that there is a cognitive impairment, we excluded these studies. So we included study that used the American College of Rheumatology battery, The ANAM, which is a computerized test to assess cognitive function, equivalent to the CANTAB in UK and Europe, for instance. There is currently more computerized tests, including the PROMIS kit and the NIH and many others. Bottom line, EndoMocha as well, which I will talk about it later on, the NMMS. So those are standardized instruments, okay? But even when you delve into this, people have used different definition to define what is impairment at the level of a specific domain, and then what is the impairment at the level of the whole concept of the cognitive function. So you can see here the heterogeneity are from different angles, different sources. And this is why when you try to look at the data and do analyze studies, it becomes very difficult. So there is no doubt it's about time to take that construct and refine the measurement about it. Because if we can measure something, we will never be able to make a diagnosis and advance the research, okay? And we have to keep in mind that instruments are different when they are used for screening, for diagnosis. And instrument should have a good measurement property when you need to measure change over time, which we call responsiveness. So technically, when you go to a drug trial, you need an instrument that can capture a signal of change, and that signal can be clinically relevant to the patient, to the physician, to the payer, whoever. But we need to refine things around the measurement to move forward with in the field.
Thank you so much. And you just explained it's getting simpler, just trying to research and understand cognitive impairment. And you mentioned the patient's reported measurements for cognitive impairment. And this is huge, but most of the times on the clinical setting, patients are just complaining of completely unspecific symptoms of, almost of the time they just say, I'm having troubles with my memory. And even other things, they don't say I'm having troubles on the velocity of my thinking. They don't say that. They just say I'm having memory problems. You need to check this because my grandmother died of dementia or something like that. So, Murray, I'm going to ask you something that probably there's no numbers for that, but you have a huge experience in your clinic. How often did patients report it to you, memory issues or brain fog? And you could actually document that with the available tools.
Yeah, well, available is a key word here, you know.
Yeah.
It's Zahi mentioned tools, but in terms of a clinical situation, you know, where you're sitting across from a patient, you don't have a lot of tools. If there's something in the clinic that's being done as part of a study, that's one thing. But just to get a tool is very difficult. So patients will complain of what you said, brain fog or cognitive impairment, et cetera, frequently. And when you're the physician, you're sitting across the desk from them. You have to decide, what am I going to investigate here? If they also have arthritis, rash, and serositis, then I don't mind saying I'll put the cognitive in with that, and I'll just treat the others and see what happens. The question is, what if they complain of nothing but that? You know, nothing but the cognitive. That's the brain fog. And we have a big problem with that, you know, and you know, we could send for some of the studies that are available. We could do some of the imaging that's available, but very often you will find nothing. And in the type 2 lupus, the people who come in complaining primarily of that, when they've been investigated, you find nothing. Now, there's a lot of research going on in that area now, seeing are there persistent cytokines, which we can't pick up easily, which are affecting memory. You know, and by the way, it's not only in lupus. How about long COVID?
Yeah.
Long COVID is lupus or chronic fatigue syndrome, you know, after an infection. And so these are the areas where you get prolonged fatigue, cognitive impairment, etc., with nothing obvious. And where the research has to be done is, are there some internal mechanisms, like some cytokines which persist in these people, which is causing this or not? But those are research questions. You asked me, what do we do across the table from the patient?
Yeah.
Try to give them, look at their, get a social worker to look at their socioeconomic situation, their home situation, get a psychiatric consultation. You know, we try to do all of those things short of having a specific treatment for them. And hopefully that lifestyle approach will give them some relief.
If
Thank you.
I may add
Of
quickly
course.
on this, because it's very important to what we're talking about. You know, when the patient comes to the clinic, and as Dr. Urowitz said, literally every other patient will say, I'm forgetting words. I was driving and I still feel I'm confused or don't know where I'm going with my GPS and so on. So those are very important, okay? But there is no doubt we still need patient-reported outcome around cognitive symptoms, because in science, something that you can measure it, you will never be able to make a difference there. And it is important to standardize things when we want to do research, comparing my data to your data in different places. We need to be able to do this and to develop new science, discover the pathogenesis of this disease, new drugs. We need tools. Tools for patient-reported and healthcare team-driven outcomes. So both are very important. But the challenge that we have right now, and we mentioned, for instance, when we measure cognitive dysfunction or impairment, the gold standard is the ACR, American College of Rheumatology Neuropsychological Battery. And we know we don't want to go very back with the history, but at least what we all refer to at this level, it's a battery for a minimum 60 to 90 minutes administration, and you need a psychometrist to administer this battery, or at least trained personnel on this. And plus, you need to add additional time to score it. And often it's not covered unless if you have a good drug plan or other issues. So there's no doubt this battery is the gold standard, but it comes with a lot of time and cost burden. And we need something that it's more practical for ambulatory setting when we see the patient. But I know we're going to have more questions around this, so I'll stop here.
Thank you so much. Zahi, Murray is really highlighting that most of the trouble that we have assessing these patients is when lupus is not active elsewhere. But actually, we even score in SLE-type the organic brain syndrome that highlights that it might be a dysfunction during inflammation and active lupus. So what would be just the background of, are there differences on the cognitive impairment type between what we know is the organic brain syndrome and the cognitive impairment during active lupus and those that we think are in remission or inactive?
Yes, very important question. Thank you for raising this question. Absolutely, there is a difference. So organic brain syndrome, which is one of the descriptors on SLE-A, and it carries a weight of 8, right? Usually, this refers to when the patient develop acute manifestation that we attribute to the lupus activity. And we know MPSLE, particularly, I'm talking about organic brain syndrome, psychosis, they cluster around the diagnosis of lupus, or at least within the first 5 years, and they become, the incidence of these manifestations become lower over time, right? And again, this is when the patient manifests with symptoms as confusion, they don't know where they are, they don't know the time, and we refer to this as organic brain syndrome. And this should be treated with aggressively. Until now, we use a lot of steroid and other immunosuppressant. So this is different than cognitive impairment. Cognitive impairment is you don't have to have organic brain syndrome or psychosis, and you don't have to have active neuropsychiatric manifestation that we know all of us within the SLE-A activity to have cognitive impairment. So your patient can be in the clinic with a SLE-A of 0, or they can have still positive serology, but they can still have cognitive impairment. There is sometimes disconcordance and sometimes concordance. But we have to remember as well that when you apply the SLE-A, it's a cross-sectional approach to things. And we often say there is no association between disease activity and cognitive impairment. You cannot look at lupus as a one page in a big, huge chapter. You have to look at the story of lupus, what the patient have survived. And maybe, I'm just going to give an approach. Maybe you need to do adjusted mean SLE day from the beginning. How much burden of disease activity they have suffered that could have led maybe to some of their cognitive impairment. And as Dr. Urowitz highlighted earlier on, it's multifactorial. Too many factors here plays a role. Not just only the lupus, the damage component, the medication, social life, and many, many other factors.
Thank you so much.
Just to highlight that in our second study, when we reported the associated features back in 2000, we actually showed that people who developed cognitive impairment had a very high SLE day at their presentation. So they went through a period of very active disease. Now they're in period 2. Is it residual active disease, or is it the damage that's done from that previous large exposure? I want to tell you, you talk about patient-reported outcomes, but the important thing is when the patient comes in and complains of cognitive impairment, the doctor has to make a decision. Is this organic brain syndrome, or is this not? Because one requires large amounts of steroid, the other does not. So it's a big decision. And I think doctor's decision, that's what SLE Day always says, this is on whatever your diagnosis has to be on the basis of doctor's decision based on clinical features and clinical manifestations. So the doctor has to make a big decision. You asked me, have I seen that? Boy, I can remember now the last patient I saw with cognitive impairment. Her sister has lupus, and she came in with it. She was so confused. They had to bring her into the office. She didn't know where she was, and she had many other features of lupus and significant laboratory tests. Nobody had any problem diagnosing organic brain lupus, and she was treated with high-dose steroids. The other lupus got better, and the organic brain syndrome got better. I wish it were always that easy. It's usually not.
As well, may I add here something? We have to remember that the brain is a hidden organ. It's not a skin that you're seeing when you see the patient. It's not transparent. It's maybe like you said earlier, Murray, the kidney. You need to reach out to the kidney, get a biopsy. You can't do this with the brain. And the tool that we have right now, and you've mentioned it already, if you talk about cognitive impairment, the scan is not going to be the best test, nor the structural MRI. And we're learning now more and more that we need more advanced imaging to get us closer to the brain, to see what's happening at the level of the brain. And often, if we can't see something, it doesn't mean it's not active in lupus. I mean, we learn about this. So.
Yes.
There may be sort of liquid diagnostic features too. You may have, there are features which show you blood-brain barrier disruption. And that could tell you that there may be some active disease going on. So you're right. We're craving the kidney biopsy equivalent. We really we need it.
Murray, you already went through the factors of contribution to cognitive impairment related to lupus, not related to lupus. So, Zahi, there's something on the paper, on the introduction, the background of the paper, that you and the other authors highlighted, that the trajectories of the cognitive impairment. So, till now, we have been discussing what is cognitive impairment and organic brain syndrome? What's the difference? What is related to? And now focusing on the cognitive impairment, even the studies are really contradictory on the longitudinal trajectories of the cognitive impairment. Is it fluctuant? Is it transient? It is permanent? And so what was the background that you could just summarize for us on this topic?
Excellent question again. And I'm going to highlight the finding from this study and give you as well a feedback on what we have done and what's in the literature. But first, I want to also give a lot of acknowledgement to initially the fellow who's now back and practicing in Israel, Dr. Oshrat Shifman, who did this beautiful, beautiful work as well. So in this study particularly, what we found that patient from visit to visit, and that's why we called it intra-individual change over time or assessment of the cognitive function. What we found that there is stability in a way in the status that the patient had. So around 50% of the patient showed normal cognitive function at baseline, and this did not change over time. And the group of patients who had significant cognitive impairment, which constituted around 17-18% of the patient, continued to stay within that group. But there is a very interesting group, and we called it indeterminate, because it's a group that we yet don't know 100% how to define it. They have impairment in one domain, but our definition for cognitive impairment is you have to have two domains that are impaired. So those patients kept flipping between having unimpairment to impaired, to normal function. And really, this is a very interesting group. And if you ask me too much about it, I don't have the right answers yet. We don't understand why they're changing from normal cognitive function to impairment. But to go back to your question, what we have learned so far that cognitive status does not change significantly from year to year, okay? Based on this study. But a few years ago, I did work with my colleagues, Dr. Patty Katz, who's at UCSF, and we analyzed data that she had over 10 years, okay? But at that time, we had only assessment on two instruments, the HVLTR, which captures the recall, and the COAT, which is the verbal memory. And both tests actually gave us the same message. Patient, again, there was a high prevalence of cognitive impairment, around 40%, but at least patient did not change the trajectory over time. So if you start with normal cognitive function, most probably you're gonna belong to the same trajectory. But if you start with cognitive impairment with significant impairment, you're gonna continue. The patients that are in the middle, which there is still some reserve of cognitive function, those are the patients that continue to fluctuate over time.
Okay, thank you. Murray, do you have any comments on this?
Yeah, so the cognitive dysfunction over time is related to something that's going on that originally caused the cognitive dysfunction. And I think those patients that Zahi just described have to be studied carefully for associated factors. In other words, can you have relapsing and remitting lupus? Of course you can. And over time, they could be more cognitively impaired and other times less cognitively impaired. Can you have damage as type 3 lupus and they'll never get better? Of course you can. And then there are those who never get any brain involvement. So that's true for lupus also. Some people are spared one organ or another. So Zahi has beautifully described the courses. The question is now, what's the underlying pathogenic factor that's giving rise to those courses? And we don't understand that yet.
But we could try.
Yes. Yeah. And that, how you could do it? You have to take Zahi and tell him all those patients, you got those patients, now let's look carefully at those relapsing, remitting, or whatever, or start a study looking at, trying to understand the underlying mechanisms. It has to be done in studies, by the way.
It's a very important question, but I want to tell you as well something. I've been careful on start tackling this question because first of all, I wanted to make sure we have enough data and that we have captured all the beautiful things. You highlighted this, Murray, that there are so many factors that can affect this construct that we're talking about, which is cognitive function. So before we start making attribution, we need to control all the confounder, the associated factor, and we needed data over time. And now we really have beautiful, beautiful data, and it's going to allow us to answer this question, hopefully moving forward. And not just only at the level of the test, we have the patient demographic. You've mentioned already cytokines and analytes, and we've been doing work around this, the interferon signature, and we're expanding to do more advanced brain imaging, model brain imaging, just to get closer to this important question that we're talking about.
Perfect.
some comment. We have not mentioned yet, but in this research study, you use the ACR battery test, which is long and costly, but it's the standard. When we discuss with the neuropsychologists the use of repeating these tests that are part of the ACR battery, we always have some concerns that some of these tests, if they are done with an interval less than 2 years, there might be a recall learning and the patients would be perform better than what is being tested because they remember. But actually, in your data, we don't see that. No. We see stability. And that's really strange. I was figuring that, okay, if they were really bad on the first performance, they probably are so bad they are not going to learn through the time. But even when they are very good on their performance, they don't perform really better at 6 months and 12 months. So it looks like there's something here that is being tested that it is not comparable to other cognitive impairments of neurodegenerative disease. It looks different, even with the limitations of this methodology. So it's really strange. Of course, on the clinic, as you mentioned before, we can't afford having ACR battery tests every 6 months, but I was amazed with the curves that are in the illustration of the paper, because I was not expecting that, taking that they were doing it every 6 months. So it's not what it is reported for other diseases performing tests. So we have discussed the persistent and the fluctuant, and you have just described that you, on the whole research, you are collecting everything. But do you think that inflammation or subclinical not detected inflammation could be running this fluctuating subgroup? Do you have any other data that could support this?
Yes, but before I focus on this question, you said something very important. Allow me to say something, because I do like how you describe things about the learning that can happen from visit to visit. And I want to mention as well that initially we were doing every 6 months. But when we saw that there is a pattern of stability in the trajectory of intra-individual trajectory, that's why we expanded now every year. And again, it takes a lot of time. We want to make sure the patient continue to be involved. But I want to assure you as well that the ACR battery has more than 15 tests in it. And each of these tests, if you take even the HVLTR and the COAT, there are different versions of this test. So it's so impossible to memorize all the tests or to be ready for it. And the proof is we've been doing this now for 4 years and the patient hasn't shifted in categories. So it's a good hypothesis, but I don't think it's solid, as you said. It doesn't stand in lupus. So that's one. To go back to your question around the inflammation.
Yes.
Very interesting question. We did a study and Dr. Munoz published a cross-sectional approach. Then we did over time as well. And we've analyzed a number of antibodies, interferon signature, analytes, and cytokines as well. Cross-sectionally, what we found, surprisingly, that calprotectin is associated with worse cognitive performance. Not only calprotectin, we found as well MMP9, NGAL, IL-6, and others as well. And we know each of these really, for instance, calprotectin can cause recurrent activation of the microglia. MMP9 is implicated in putting defect in the BBB. So it makes sense as well, the results that we have found. And interestingly, again, going back to the calprotectin, not just only cross-sectionally, we followed the patient after 1 year and we repeated the cytokines. And we found that the level of calprotectin, when it goes high, the cognitive function is getting worse. And when it's dropped, the cognitive function is improving within the same patient. So this is why now this was a data within our center. What we're doing now, we're doing an external validation and recruiting patients from different centers around the world to validate our findings around the cytokines cross-sectionally and over time. And hopefully down the road, we can maybe have something to target these these analytes and cytokines. Now, if you look at the traditional inflammatory markers, ESR and CRP, they were okay in these patients. There was no association between the analytes and cytokines, including IL-6 and calprotectin, MMP9 and others, and ESR and CRP. So there was no ongoing inflammation to explain the high level of these analytes and cytokines. And if we look at our traditional biomarkers that we have in lupus, DNA and complement, they did not explain what we're finding at the level of the cognitive function.
Thank you so much.
So that's really the very interesting question, isn't it? That how does the basic disease leave you with abnormal cytokines, etc., afterwards, which cause their own problem, right? So they're the problem, even though the first line stuff, the anti-DNA, CRP, and etc., are not there. That's a very important question.
Yeah.
Is that the screening that we should be doing in our patients?
And, to add more small complexity and nuance at the same time, that some of the cytokines and analytes, like the NGAL, particularly, was more elevated in the group that we defined undetermined. This is the group that has only one domain, yet not two domains. And our hypothesis that each of these cytokines and analytes plays specific role at a certain time in the trajectory of deterioration in the cognitive function of patient.
Right, and persist when the first line immunopathogenic mechanism is subdued, gone. These persist. So something has happened earlier to trigger these, which are long-lasting. And I think that's the kind of research we need now, and I think that's very important.
And some of them are interferon-driven. So some of these cytokines are kind of the end of the interferon-driven. So it comes back to you, Murray.
Yeah.
How would you change the activity lupus scores, taking these into account?
How would I change this?
So how do you see the lupus activity scores?
Yeah, it's a hard question. We grew up with this all the time, but the lupus activity scores, the activity score is based on clinical features which are immunologically, inflammatorily developed, right? So those are the reasons. And that's why I said we're on the first level of the disease mechanism, immunopathogenic mechanism in lupus. The second and third levels aren't reflected in the activity scores at all.
Yeah.
And it's the same thing I told you, like in long COVID or after infectious mono, with the chronic fatigue syndrome, something happens during the acute event, which goes away, but leaves them with these abnormal circulating immunopathogenic mechanisms. And until we understand those, we can't put those into the activity scores, right? The activity scores reflect what we see when we see a patient that we diagnose as active lupus.
Zahi, on the paper, when you compared the never impaired with the persistent impaired, you found some statistical markers that distinguish them. And how do you think that they are different, what you found, from what was already known and proved?
Not a lot, okay? And I want to highlight something important here, that the strength of this paper is the description of the intra-individual trajectories, okay? And really that was the main purpose of this paper, but we were asked to add regression analyses and associated factor. So I want to be transparent that this was not my aim in this paper, and I kept fighting back not to have it, but I had to include it at the end. Because as I said earlier, we felt it's premature to start distangling this question.
Okay.
And the whole idea of this paper is to describe the intra-individual trajectory, but I'm going to try to answer your question. Some of it, yes, in the descriptive table, it showed differences, okay? And I always would be very careful referring to any p-value in a descriptive table. And if you ask me, a p-value should not be reported in a descriptive table, because that can mislead the readers, okay? And yes, there was a difference between the age there. The group that had persistent cognitive impairment, they're 32 years old, mean age, and the other group is, I think, 20 years old at the diagnosis, 20 years old. Statistically significant, but really, do we think there is a difference? I mean, these are young patients, 28 or 32, despite being statistically significant. For me, this is the same group age, okay? So this is why we have to look at the statistical results. Even if the p-value is significant, doesn't mean anything clinically. Having said this, yes, the age was there more. They were a little bit older in the group that had persistent cognitive impairment in all visits. And we found other associated factors as well, but particularly related to racial or ethnical background. But those are very critical how to analyze, because we already know, and there's a lot of literature behind it, that racial and ethnical background are different concepts to analyze, and especially when we start putting this in our models, because there are so many factors that surround and affect the racial background that has an influence as well on our results. Socioeconomic status, education, access to care, all this itself, we know already, is associated also with bad disease activity to start with. So it's not a surprise that the same group of people that we always see in the minority of lupus patient, of minority, I mean racial and ethnical background, they have the worst lupus. Patient of Black descendant, Hispanic, and other minorities, they do have bad lupus. But also when we analyze the socioeconomic and other factors related to this particular group, there also has a huge impact on the disease activity, the management of lupus, the access to care, and I want to add as well cognitive impairment. It's the same patient.
But when you did the multivariable, none of those came out, you know? And I think that was just a numbers game.
Exactly. Yeah.
Yes. Murray, part of the results are that previous cardiovascular events and abnormal brain imaging were more prevalent on the persistent cognitive impairment group than the never cognitive impairment group. And it looks like obvious, but do you think that this macrovascular disease and the abnormal MRI are the only explanations for the cognitive impairment? These inflammations, this inflammation, persistent inflammation, and microvascular injury, what do you feel about it? And
yeah, so I think that's important, because that may be the first sort of underlying cause that we may eventually agree upon. If you take older people who are progressing into dementia, and you say, oh, is this Alzheimer's? Is it something else? And then there are a group of those people who on microvascular evaluation show multiple microvascular disease, and so this is called vascular dementia in the aged. Now, in lupus patients, it's going to happen in two ways. You can have microvascular active disease with part of active lupus, and then you probably would see it elsewhere in the body as well. Or you could have the type 3 lupus damage. And what's the damage due to? This happens later. So damage to blood vessels is probably the accelerated development of atherosclerosis. So we could talk about what causes the atherosclerosis, but accelerated atherosclerosis. The common manifestation is the heart or the peripheral blood vessels in the legs, but it is also possible to have it in the brain. So if they had microvascular disease in the brain due to atherosclerotic disease, this would happen later in lupus, not early, right? But later, they developed it in the brain instead of the heart. I think that is a real possibility. And if I had somebody who was 13, 14 years into their lupus with dementia and I'm investigating and I saw microvascular disease and no active lupus elsewhere, I would probably attribute it to atherosclerotic vascular disease.
Zahi, do you want to comment on this too?
And again, the study here echo what you're saying, Murray, because we found actually association with the particular component of atherosclerosis when we look at the damage in patients with persistent cognitive impairment. So there is no doubt, as you've highlighted regarding the microcirculation and the blood supply to the brain and atherosclerosis. And really, this is not the first time that we're finding this results. We've done a study probably 2 years ago. Dr. Michelle Baraklov led this, and she did a type of machine learning network analysis of the data. And we described two phenotypes of cognitive impairment. One of them actually that was the severe phenotype, and one is a little bit milder. And again, we found also that the severe phenotype of cognitive impairment did have more damage, particularly at the level of atherosclerosis. So it seems like there is an association, but again, we have to remember that when we find an association, it doesn't explain everything and it's not applicable for every patient. Really, it's way more complex than this. And every patient comes with a specific phenotype. And that's not unique for the brain. Lupus is like this. The skin, so many diseases in the skin, in the joints as well, we're learning more and more. Some patients do develop erosion, others don't. Some patients do develop Jacquards and others don't. Why and how? We don't know yet.
Thank you. So, Zahi, there were particular domains that were more heavily impacted than others on the ACR battery tests. Do you think that this is something specific for lupus? And how do you find this on the impact on the patient's daily life?
Great question again. And I do believe, yes, it's like maybe a signature for lupus, because the patient, when they come to the clinic, the first thing they mention, we said it early on during the meeting today, is forgetting the words. So there is no doubt there is a problem with the short memory and their ability to learn new things and multitask. And that's a patient-reported things. But when you do the test as well, what we're finding at the level of the impairment particularly is the learning and memory is one of the most commonly affected domain, and visuospatial construction, simple attention and processing as well. And when you follow the patient over time, there is a stability, kind of the same pattern of domain that are impaired. What we found in the study, that patient did not change domain impairment from visit to visit. The same domains continues to be impaired. So, and particularly in those who are persistently cognitively impaired. And we know that the brain different part has a reflection probably on certain domains. So there is no doubt here that study after study is showing this. And when we did interview the patient, we did a qualitative study, when we tried to mirror the findings of the cognitive function with what the patient would tell us. And again, it was the same story here. So back to your question, I think, yes, there is specific certain pattern or signature in terms of the domain for patient with lupus, what we're seeing here.
Thank you so much. We already discussed the impact of the socioeconomical issue, so I'm moving a little forward. And to all these findings that we have been discussing would affect the clinical setting. So, Murray, what would you advocate for screening cognitive impairment in SLE? Would you screen it? Would you screen only if there was symptoms? How would you screen it?
So rather than great question, I would say terrible question. It's only going to get a terrible answer. That is one of the most difficult things we have clinically. When the patient comes in and cognitive is the worst problem, what we do, and we think that the lupus is not active, right? So we're left with dealing with cognitive alone. We're at the mercy of what's going on in the clinic around you, right? And that's what I was saying the difficulty is. Now, luckily in Toronto, we have Zahi, so we could say, could this go into your study? Would you do the ACR battery? Help us get that done. In a clinic not focusing on neurologic research, it would be very difficult. So you would do what a clinician could do. You would do some CNS investigation. You might get an EEG. You might get a CT of the brain. You might get a vascular imaging of the brain. But you're really, I hate to sound this way, but you're really stuck on what's available to you in your clinic for investigation, which is why I say studies like Zahi, etc., they're leading us into what we should be looking at in the future, and then everybody could be doing the same tests. I don't think in most clinics you could get an ACR battery. You're talking an hour and a half. By the time you do the investigation and the follow-up, it says 4 hours, of a costly test. So we're looking to the investigators to tell us, which are the key tests, And in the lupus biopsy, they say they want a liquid biopsy, and that'll tell them everything. Is it active or not active? I want a liquid biopsy.
For the brain.
Of the brain. I want Zahi to tell me, here are the markers that indicate active lupus in the brain, not the classic markers, but the specific markers. Then I'll feel very happy.
Yeah. So I want to tell you, should you do screening for cognitive impairment? Absolutely, yes. Do you measure proteinuria? Do you get urine sample when you see your patient? Yeah. You need to look at the brain, okay? Maybe we don't have yet solution, but if we don't start, we will never make a difference. So every patient should have a screening. The ACR battery has a lot of cost and time burden, and that's why we have generated evidence around a computerized test that can serve in the clinic while the patient are waiting to be seen, or they can complete it before coming to the clinic. And it doesn't take more than 15, 20 minutes. That's the best screening tool that has good evidence against the gold standard battery. We tried with the Montreal, the MoCA, and the MMSE, and it's not recommended for screening for cognitive function in patient with lupus because it doesn't tap on the problem that the patient has, the lupus patient. Those tools were developed and geared toward dementia. The problem of lupus patient, they know where they are, they know the date, and they know the time. That's not the problem. So if you want the MoCA to work, you need to change the weight score of the MoCA. And that's why I would not recommend using the MoCA if you're doing research study to study cognitive function in patient with lupus.
Thank you so much.
Clear about
let me plead, let's get out that simplified test that we could use in clinics generally. That's really what the screening test that we make us confident that this, yes, is cognitive impairment, and we can follow it over time.
Murray, this is going to be a long podcast, so we are almost going to the end, but I need to ask something. And Murray, you have years of experience, and with the exploratory model that is presented on this paper, it shows that immunosuppressive therapy use had a modest positive association with learning and memory scores and steroids, and the steroid load altered the visual spacing construction. I could ask you several things about this, but we're not on the step to use immunosuppression for cognition, but are we on the step to think which immunosuppression we should use to prevent cognitive impairment? Sorry.
It's a very important question. It goes back to what Zahi is saying, that we have to better categorize the type of cognition impairment. In other words, you can't say immunosuppressives will be better for this specific domain. We're certainly not at that level. I wouldn't talk about that at all. And I think that we're only going to learn this, when large studies come out showing us cognitive impairment. You look for associated factors, then we can look at treatment as the associated factors, and not only treatment at the time of the cognition, treatment before the cognition. Like steroids will have a dramatic effect, and then you reduce the dose of steroid, but the dramatic effect on the brain may remain the same, right? So when we're looking at associated factors, we have to look at not only at the time of the diagnosis of cognitive impairment, but the disease trajectory leading up to the present time.
We're getting there slowly, but to get there, we need instrument, standardized instrument and definition. We need biomarkers for the brains. We need the analytes and cytokines that can change over time, right? And there is an ongoing trial by my colleague at the Feinstein, Dr. Megan McKee, around the use of central of ACE and ARB to see if they can make a change at the level of cognitive function. My previous master student, Dr. Christiana Dobrowski, did study the association of immunosuppressant that crosses the BBB and the cognitive function. And what we found in her study, that Imira had some kind of, I want to say, a protective effect toward cognitive impairment, but those results should be looked very carefully because there is a lot of bias around this, and it's more indication by bias when we use these drugs. So we need really good study design and trial to answer these questions moving forward.
Thank you so much. Zahi, do you have any additional final comments to this topic?
We cannot ignore the brain. We need to work, all of us together. It's the new chapter you're gonna see a lot of innovation, and hopefully very soon we will be seeing a lot of trials focused on neuropsychiatric lupus.
Thank you. Murray.
So I agree. Oh, sorry.
How would you close this podcast episode?
Don't close it. This should go on forever because this is an ongoing problem. But I would say we need better categorization of this disease. So when we see a patient with lupus, I'd like to know, are they type 1, type 2, or type 3 lupus? Are they people who have active disease? Are they people who have type 2, which is the brain fog cognitive, but no active disease? And 3, do they have damage? If categorize the patients into that, and then give them to Zahi and say, okay, Zahi, for these 3 type of patients, active disease, cognitive but no active disease, and 3, damage due to previous disease, okay, Zahi, give me your markers. Do the markers appear in these 3 groups equally, or do they differentiate them? And, when we get those kind of markers, especially those liquid markers that he was talking about, then I think we can advance our approach and our therapies.
Zahi and Murray, thank you so much for joining me today and sharing your insights into cognitive impairment in patients with systemic lupus erythematosus. The publication we have been discussing can be found in our show notes. To summarize, the study showed that over a 1-year period, the majority of lupus patients retain stable cognitive functions, either completely healthy or persistently impaired. However, close to a third will fluctuate. It is important to look closely at your older onset patients, those with existing neuropsychiatric and other risk factors that could be more vulnerable to permanent cognitive damage. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.